This podcast is being recorded on the land of the Bunurong people of the Kulin Nation. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa, New Zealand, and is committed to meeting its obligations as te tiriti or Waitangi partners.
This podcast is not sponsored by any pharmaceutical companies. We aim to provide balanced, evidence-based discussion without commercial influence, and wherever possible we refer to medications by their generic names. We acknowledge the value of any new methods of contraception, noting that the availability of these medications may differ between Australia and Aotearoa, New Zealand. Welcome to Talking O&G, a RANZCOG podcast. This podcast takes a closer look at the latest RANZCOG guidelines and ANZCOG evidence through in-depth conversations with leading experts in obstetrics and gynecology. I'm your host, Dr Heather Waterfall. I'm an obstetrician and gynaecologist based in South Australia, where I'm the chair of the South Australian Northern Territory RANZCOG Committee. In this episode, we're focusing on RANZCOG's newly released Australian Living Evidence Guideline on endometriosis. This guideline sets out to improve patient care and outcomes through up-to-date, evidence-based recommendations. Before we dive in, I'd like to clarify that this episode focuses on the guidelines from a clinician's perspective. We recognise how important it is to listen to and learn from those with lived experience, and we'll be exploring the patient perspectives in a follow-up episode to come. Today we're joined by two expert clinicians who are both instrumental in developing the endometriosis guideline that we're discussing today. Professor Cindy Farquhar joins us. Cindy is Dean of Research and Policy. She also chaired the Guideline Development Group. Welcome.
Thanks for having me.
And Dr Marilla Druitt. Marilla is an obstetrician gynaecologist with a special interest in endometriosis. Marilla was also a member of the Guideline Development Group. Welcome.
Thanks for having me.
Let's start with the big picture. This is now a living evidence guideline. Cindy, what does that mean in practice for Australian and New Zealand clinicians?
So that's going to mean that we will be looking for new research studies every 3 months. And if that new evidence is likely to change the recommendations, then we'll reconvene the committee and make changes to the recommendations, and we'll just keep on doing that through over a few years. I don't know how long it'll go on for, but that's the idea. So you've sort of got the benefit really of being much more responsive and nimble than waiting for a 5-year update or something like that.
Fabulous. Cindy, the guideline no longer recommends laparoscopy as the only pathway to an endometriosis diagnosis. Can you tell us what the recommended diagnostic pathway is now?
Yes, so I think this was the really great thing about this guideline is that there's been a lot of new studies around the role of ultrasound in diagnosis, and so I think we can be reasonably confident. The studies show that you can rule out endometriosis. That's kind of called high specificity, and then for the sensitivity, particular locations such as the ovaries and deep endometriosis, there was high, moderate and high sensitivities, and for other parts of the pelvis, perhaps not so confidently diagnosed, but still suggestive of a diagnosis of endometriosis.
So in terms of the evidence to support imaging, what you're saying is it's a very reliable tool where you've got ovarian and deep infiltrating endometriosis.
Yes.
But not so much for more superficial endometriosis.
Yes, that would be correct. But at the same time, it just sort of emphasise that those studies have been done by people who've got a focus of endometriosis, ultrasonographers and radiologists and it's within a research setting, so it may not be quite the same as our local radiology groups around Australia and New Zealand. So there's some work to do perhaps with trying to work out, what does a woman's health radiologist and ultrasonographer look like. We've also emphasised that if you can't have a transvaginal ultrasound, you can also rely on the transabdominal ultrasound and MRI. So a couple of things as an alternative to transvaginal ultrasound if you don't want to have that.
Yeah, I think that's really interesting. There's certainly been a lot of discussion about the quality of the ultrasound scans we're being provided with, and certainly some of the local ultrasound services that provide a transabdominal ultrasound. I don't think we'd be happy to trust that would rule out endometriosis with good enough sensitivity.
Yeah. Okay, yes, I take your point about that. It does pick up endometriomas for sure.
Definitely.
So I think that's a really important part of this. So it may not get everything, and that's why the MRI for the deep endometriosis.
I suppose emphasising the need for more excellent quality, well-trained sonographers and women's health sonologists to support this work is so important.
Yeah, that's right.
So Cindy, Marilla, what about cases where imaging is normal but women's pain and their symptoms persist?
Pain is complex and usually has lots of contributors, of which endometriosis absolutely might be one of them. And so we should always take a whole person approach with everything that we do in medicine, but particularly in pelvic pain and subfertility. So I think I like the emphasis that we've made on get going with symptom management alongside looking for endo, because we really don't want people to miss out on starting treatment, because we know that the treatments can be so effective. And this is obviously with shared decision making, because if you boss people into stuff they don't want, it's more likely to not work and they're more likely to have side effects. So presenting all of the options at the beginning, but getting going and not delaying treatment. So I don't know about you, but we have had a lot of referrals over the last couple of years of people who are reluctant to start treatment before they get their diagnosis of endometriosis. And that is such a waste of time. So we really want people to get going with treatment at the same time as diagnosis. So specifically, you're saying if someone doesn't have deep endo on a scan or a nodule that they can see at ultrasound or MRI or an endometrioma, sure, they could have superficial endometriosis, but either way, they can still get going with treatment. So it's always possible, but it shouldn't delay our treating of symptoms.
Definitely, especially if there is a delay to being able to obtain a laparoscopy, encouraging our patients to engage with multimodal treatment wherever possible before they consider surgery.
Sure.
We'll be back in a moment after a quick ad break.
Hey, did you know that RANZCOG Education and Engagement Days are coming to Perth in August? It's a new RANZCOG event series that's smaller, locally focused and tailored specifically for members and trainees in each Australian state. The Perth event includes a day of hands-on workshops and a networking dinner, and a day of presentations on topics relevant to the WA context.
That sounds ideal. I love that it's local. That's less time travelling, less time away from home and from clinical work.
Exactly. And because it's WA based, it's a great way to build real clinical connections with people working in your area. It's not just about learning, it's about building community.
I'm interested. Where can I find more?
Head to ranzcog.edu.au/RANZCOG events to check out the full program and register.
Welcome back, everyone. Marilla, this guideline emphasises the multimodal approach to the management of pain associated with endo. Can you talk us through the different hormonal treatment options that are available to manage endometriosis?
So we've got a big, beautiful table of all of the hormones that you can use. And so down on the left-hand side, there are the combined pill, progestogen-only pills and implants and injections. And then the second line, GnRH analogues, antagonists, and then the likelihood of amenorrhea with each of these agents and the possible adverse effects or unwanted effects. And so we've got heaps to choose from. It would be fantastic if we could predict who's going to like what, but as we all know, we don't have that yet, but it's good to know that there's heaps of things to choose from. So I think that allows doctors to talk to their patients and say, here are all the things, here are the pros and cons. Do you also need contraception? Does it depend on cost? And, how are we going to get this thing into you? And so then people can, choose what's going to be the right thing for them.
Fabulous. Marilla, I know the guideline really tries to address concerns regarding our hormonal therapies and in particular around GnRH treatments. Could you explain for us how clinicians can manage the risks of GnRH treatment while still supporting effective care with these newer medications?
We have to present all of the possible pros and cons to our patients and make decisions together. on what they feel is acceptable to them. These are good, safe treatments. And again, you have to be happy that you're getting more benefit out of your treatment than harms, and only the patient can report that. It's not up to us to say, we think that your amenorrhea is trumping the, whatever thing you don't like, such as, I don't know, mood disturbance or, whatever is not acceptable is not acceptable. There is a table that addresses all of these concerns. Going on one of these GnRHs is a temporary menopause. They're all reversible. We recommend add-back therapy from the start to protect your bones. There are some PBS requirements in Australia about checking bones with the DEXA, which is, nicely documented. Have a read. But essentially, these are good, these are good treatments. And I was just at the World Endo Congress, and somebody presented the data for hormones being anti-inflammatory, and loved that. That was super helpful. So we've got a bit of understanding about the mechanisms for why they can be useful. But in the end, the person tells us if they're useful or not. They're either useful or not. And this is for pain. This is obviously not for fertility problems.
Yeah, I think there's some definite benefits from hormones that are, including contraception and whether it could be beneficial for your skin, as well as helping with endo pain and things like that, which sometimes I think some of our women do forget about. You touched on the bone mineral density checks, and I think this has been highlighted specifically with the PBS requirement in Australia for the new medication RANZCOG. Can you talk us through what the concerns are with RANZCOG and bone mineral density?
Sure. So the less estrogen you have, the less time you have support of good bone health. And so we need add-back to ensure that we don't create a new problem. So bone mineral density drops, but then it seems to steady after that. And so it seems prudent, and it's also part of some PBS that we check it at the beginning, because if someone's already got a bone problem, well, then maybe that's not the right medicine for them.
Yeah, definitely. Cindy, can we talk about endometriosis treatment and its impact on fertility? As a laparoscopic gynaecologist for women that have endometriosis, can you talk us through the removal versus whether we would preserve endometriomas at the time of laparoscopy and the impact each approach has on ovarian reserve?
Okay, so the guideline didn't go specifically into fertility treatments for women with endometriosis, but it focused on preserving fertility. And there have been quite long-standing concerns about taking ovarian tissue away at the time of doing a excision of an endometrioma. And so there's this sort of trade-off between drainage and ablation and the higher recurrence rate and return of pain with that compared to having excise. So if fertility is not a concern, definitely recommend the excision. If fertility is a concern, but you really do want to avoid a recurrence and you've got pain, that's a little harder. But we were reassured by the evidence from randomised controlled trials that the AMH levels between the two groups, ablation and excision, were not actually different at 3 and 6 months after the surgery. So maybe we've been overly concerned about that. And but obviously a careful excision or judicious, and trying as much as possible not to disturb the anatomy too much.
So judicious use of diathermy, judicious use of any energy that might damage the ovarian stroma that we're going to leave behind. But focusing on the woman's history, and if pain is a significant concern, that removal of an endometrioma, even for women who are considering fertility as a concern, it's still acceptable to remove an endometrioma if we think that's the cause of their symptoms.
It's certainly associated with reduced recurrence and return of pain, so that does seem to make sense.
Fabulous, thank you. This guideline now gives targeted advice for caring for young people with endometriosis. Marilla, how can clinicians support early diagnosis and care for adolescent women?
So around 70% of adolescents and young people experience period pain. So this is a universal experience. It is really common. but it's not acceptable, or at least anything that you're not happy with is reasonable to want treatment for. If it's interfering with school or doing the things that you like or sport, or, if it's mucking up your life, it's not good enough, because, we're having unprecedented amounts of numbers of periods these days. We're doing something that's evolutionarily unprecedented. So whether or not endo is confirmed, pain is real. These people deserve a whole person approach like everybody does. And the broader we go, probably the faster everybody will recover. So they can be assessed early. Age does not mean that you can't have treatment. And these are lots of treatments that are safe and good. Imaging is tricky, but a 26-year-old might not want a vaginal scan, like a 15-year-old might be perfectly fine. So it's all about consent. And we should talk to people and say, here are your pros and cons of your different imaging. What do you think? Like, what might be acceptable to you? Obviously, we're looking for other things. Like, endo is not the only thing that causes pain in teens. And so we need to check to make sure that they don't have a Müllerian anomaly, they don't have some extra uterine horn. And so we're using imaging to exclude other problems. And certainly I think parents and young people should feel reassured that trialling hormonal treatment is safe. It's one of, some of the safest drugs that we've ever had. And the sooner you get going, the faster you get better.
So you'd be comfortable starting any of the hormonal therapies in younger women?
Well, mostly everyone starts with tablets, but it depends on what else they need. Like, they might need an implant for contraception, again, if the person is up for it, we should talk them through their pros and cons and see what they want.
Mm-hmm. Fabulous. Mm-hmm. Do you want to add anything to that, Cindy?
Oh, well, just, to piggyback on to the safety aspects of it amongst adolescents. I mean, the pill's been around for nearly 70 years. It is the most, probably the most studied drug, and with the largest number of patients that have been considered. So I'm very comfortable with that part of it. And even with the other progestogens, there's now a lot of data around, particularly the intrauterine device with progesterone, with levonorgestrel, I should say.
We know that many marginalised communities, such as First Nations people, trans and gender diverse individuals, and people living with disabilities face greater barriers to accessing equitable and quality endometriosis care. What does the guideline recommend to help clinicians better meet the needs of these groups?
First of all, I'd like to acknowledge that First Nations peoples were the original practitioners of holistic and biopsychosocial approaches to health and well-being, and many of them have their own solutions. It's encouraging that we can now explicitly recognise this by incorporating the cultural safety, social determinants and community-led perspectives for endometriosis care. And we have highlighted that there is a need for culturally safe, trauma-informed care, and recommend that clinicians partner with First Nations health services wherever possible. And much of this will hang off the need to improve access to diagnosis and treatment and support services for First Nations people because of the systemic barriers to care and the challenges of a remote and rural populations.
Marilla, your thoughts?
Anyone with a uterus can develop endometriosis, and so that is anyone who's born with a uterus. So women, non-binary people, trans people. So it should always be a thought whenever we're seeing someone who has been born with a uterus. And so it might be higher in this group and lower in this group, but we should always remember to factor it in and acknowledge it. And so for some people it will matter and for others it won't. We think that it's good practice to ask people about what language they want to use to describe things in their pelvis, because often this can be contributing to their gender dysphoria, and we're not here to make anyone feel worse. We're trying to help people recover. So often we'll muck up our language and then we apologise and move on. It's always an evolving process, and for a lot of people I think that this is a new thing to factor into your medical practice. but we should always be learning. So we should welcome, new perspectives and be, partner with our patients to get the most out of consults and decision making and care.
But from a trans perspective, is there any different management of endometriosis, or it really follows the same pathways?
Yeah, same pathways. So for some people, they really don't like bleeding, and so they don't want to bleed. And trans or not trans, that's, we need to work out what the patient goals are and work out the pros and cons of our treatment and what will be acceptable and what won't be acceptable.
Achieving amenorrhea for our trans people would probably be a higher priority for them, and I suppose focusing on or offering them treatments that would achieve that for them would be a priority.
Yeah, absolutely.
Cindy, this guideline also clarifies the risk of cancer in people with endometriosis. What should clinicians be saying about cancer in terms of endometriosis? Can we reassure our women?
Well, I think we can reassure them that there's definitely growing evidence to show that there is a small increase in of ovarian cancers in women who have endometriosis. But when you look at it, ovarian cancer is, a rare cancer, and the two types of ovarian cancers, the clear cell and the endometrioid cancers, represent 1 in 5 of the ovarian cancers in Australia overall. And when you double a small number, it's still a small number. So we need to say, yes, it's there. I think to be reassuring that it's nowhere near the same as the risk of if you happen to have a genetic variant that puts you at risk. And that there's no screening for ovarian cancer or for endometrial cancer for that reason, for that matter. And so know about it, perhaps, but don't get too concerned, as it's pretty unlikely. I think it went from 1 in 100,000 to 2 in 100,000 women per year, so it's that's a pretty low number.
But then, maybe then that's the opportunity to say, okay, well, if you don't want cancer, what actually can we do about it? What are all the other things that we can do?
Previously, we've talked about women who, as their definitive surgery for their endometriosis, end up having a hysterectomy and their ovaries removed as well. Does the guideline have anything to say about what we should do with women's ovaries when they've finished their childbearing?
No, we didn't.
No.
We didn't cover that question, but it is covered in another statement of the college, or another guideline from the college. So,
which I think is that managing the adnexa at the time of hysterectomy for benign conditions.
Right.
Nice work, Heather.
And there's concern about the impact of bilateral oophorectomy in older age, and chronic diseases, bone disease, cardiac disease. So at the moment we've discussed that, the benefits and risks, and people make up their own mind.
So individualised care, but we're not recommending a blanket oophorectomy for women with endometriosis
Absolutely
at any point.
not.
No, good.
Your pros have to outweigh your cons.
There is still some women, some consumers will come and they'll say, I'm done with this.
I know.
And
Take it all out.
Take it all out. Take it all. I don't care. I just want my pain to be gone.
Well, that's fair.
It is.
But, what happens if it doesn't? And what happens if you end up trading one thing for another? You have to be fully informed.
Absolutely. Marilla, I don't think we've talked about the multimodal options in terms of what we can do outside of us as gynecologists.
Oh, well, I was worried if I started I wouldn't stop. So what I'm really happy about this guideline getting to the stage that the psychology and physiotherapy research is at the level that now it is good enough to be able to say, yes, we recommend it. Because certainly we work with practitioners and we know that what they do helps our patients recover from a pain perspective to do with endo. And so it's lovely that the research has finally caught up with what we've seen in clinical practice for a long time. So physiotherapy is good for pelvic pain and pain with sex. Psychology has evidence for treating pain. And so that's a big paradigm shift to hear in gynecology land, I think. So I'm pretty happy about that.
Yeah, fabulous. And I think for our Australian gynecologists, encouraging our GP referrers to put us down as members of a chronic disease management plan to try and improve access for women to get good quality physio and psychology is really important, I think.
So the chronic disease management plan is for allied health, physiotherapy, and then your mental health care plan for access to partially rebated psychology services in Australia at least.
Before we wrap up, what's one practical takeaway you'd like our audience to take from this guideline? Let's start with you, Marilla.
So I'm pretty happy with the quick reference guide for primary care and this fabulous flowchart on the back that says you can get going with treatment, don't delay, you can make a diagnosis of persistent pain after 6 months. People may or may not have endo, and so simultaneously you are offering treatment to help people recover faster, as well as continuing with investigations to look for endometriosis.
Cindy, what were your thoughts?
Well, I very much echo what Marilla's just said. I really would hope that this earlier diagnosis and earlier treatment, we should be able to reduce the delays in diagnosis that we've been seeing and seen reports of. So I guess I'm concentrating on the front end of the guideline, and I just really hope that it's going to make a big difference, that people can get onto treatments earlier.
Acknowledging that their pain is real and acknowledging that surgery is not the only answer and that we can look for endometriosis in other ways, and we can manage endometriosis with a multimodal approach, medications, physio, psychology, and our allied health support, and then moving on to surgery if we need to.
That's a very good wrap-up.
Fabulous. Thank you, ladies.
Thank you.
Thanks so much to my guests, Professor Cindy Farquhar, Dr Marilla Druitt, for your insights. It's been a great conversation. You can read the full Australian Living Endometriosis Guidelines on endometriosis on the RANZCOG website. We've included the link in our show notes. If you've enjoyed today's episodes, please review, subscribe, and while you're at it, why not share the podcast with a colleague? It's a simple way to help others find Talking O&G, and log this episode for your CPD. We'll be back soon with more conversations on the issues that are shaping obstetrics and gynecology across Australia and Aotearoa, New Zealand. Thanks, everyone.